Thank you very much, Clarissa, for your kind words of introduction. I'm also grateful to Canon for arranging this talk, and I hope to be able to share some of the latest research data and also some of the guidelines that help us as busy obstetricians and gynecologists to manage our patients at high risk of fetal growth restriction. So today I will concentrate on the diagnosis and management of early and late fetal growth restriction. And again, I'm grateful to Canon for sponsoring this talk. I think the important clinical distinction here is that we need to make sure that we are assessing the right pregnancies that are actually growth restricted. And of course, there are lots of prerequisites for this to take place satisfactorily. I've listed some of them here. It is incumbent upon us as obstetricians to make sure that our pregnancies that we're looking after are all dated accurately, and you need to have that information from the first trimester scans, of course. We need to be sure that we are using the correct fetal growth charts in our departments and our hospitals. It is also important that whilst we concentrate so much of our efforts on placental fetal growth restriction, let's not forget that there is a substantial proportion of small and growth restricted fetuses that are small or growth restricted because there is an underlying chromosome abnormality like a microdeletion, or because there is actually a fetal infection due to maternal infection. And we're looking at organisms such as CMV, toxoplasmosis, and parvovirus that can lead to this. So it is important to make sure that we have done our prior work to make sure that our fetuses have at least been excluded from these possible causes, other causes of FGR or fetal growth restriction. We'll spend a little bit of time talking on prevention of fetal growth restriction and the role of aspirin, low-dose aspirin in this situation. And then I'll launch mainly into the talk today to distinguish between smallness for gestational age and fetal growth restriction itself. Then distinguish between early and late FGR. How do we monitor our early FGRs? When do we deliver our early FGRs? How do we deliver our early FGRs? Talk a little bit about the late FGRs and the problems we have in diagnosis. And of course, I'll cover a little bit of ground on the role of dexamethasone and also magnesium sulfate for neuroprotection, especially in early FGR. And I'll finish with maybe some of the future trials that may be coming upon us, as well as some of the interesting, exciting new technology that can help us to evaluate growth-restricted fetuses, in particular the placenta in growth-restricted fetuses better. So I think the premise of fetal growth restriction is based upon the assumption that the pathology happens before week 16. And this is the primary pathology that we are looking at here in this graph, in this particular diagram, where we assume that when there is a healthy second wave of the trophoblastic invasion of the spiral arteries at or by 16 weeks of gestation, we then have very healthy placental function. And if there's a failure of this trophoblastic invasion of the spiral arteries by the 16th week, then we assume and we believe that the pathology of FGR has already been set, and we see the clinical manifestations weeks and months later. And that is why when we started doing work on this, like in the 80s and 90s, we were looking primarily at the uterine artery Dopplers, mainly in mid-trimester, but it took us a few years or maybe a decade later to realize that we should really be moving our screening into the first trimester if we are going to make any headway in preventing FGR in the first place. And this is a summary meta-analysis of the studies that have looked at the possibility of aspirin, baby aspirin, low-dose aspirin, in preventing growth restriction. You will see from this particular slide that when you look at growth restriction, the use of low-dose aspirin can actually reduce the incidence of FGR or growth restriction by 20%. Doesn't sound as exciting as the reduction in risk of severe preeclampsia, where we believe that low-dose aspirin can actually reduce the chance of preeclampsia developing by a factor of 60 to 70%. So you get an odds ratio of 0.37, far more impressive than an odds ratio of 0.8 for fetal growth restriction. So basically, I think the story is that low-dose aspirin works in preventing growth restriction, but not as well as preventing severe preeclampsia. We move now to the point which is not just philosophical, but actually practically important, and we need to distinguish between smallness for gestational age, SGA, and fetal growth restriction, FGR. We believe that SGA is constitutional and there are no signs of adaptation. The perinatal outcome is normal, whereas in true fetal growth restriction, the pathology is placental insufficiency and there is a poor perinatal outcome. Therefore, we should distinguish between the two. For SGA, there's expectant management. For fetal growth restriction, there's active management. Now, how do we tell one from the other? Well, if we looked at size per se, fetal size alone is not really sufficient to identify fetal growth restriction unless we have a AC or an estimated fetal weight that is below the 3rd centile. And these are some of the points that have been highlighted in the ISWOC practice guidelines, which I'll be referring to quite a lot today in my talk. However, if you have the luxury of time and you can monitor the fetus over weeks, and you've noticed that there is a drop in the centiles of at least 50 centiles or 2 quartiles of drop in growth, then we can also quantify that fetus as being growth restricted. In practice, most of the time, we depend on the Doppler studies of either the uteroplacental circulation and or the fetal placental circulation to tell us whether the fetus is SGA or suffering from FGR. The point being that in SGA, the Dopplers are normal, and we usually would triage them to become a low-risk pregnancy, expectant management, whereas for FGR, we would be monitoring the fetus very intensely. Well, I've alluded a little bit to the measurements of size, and of course, this requires good, appropriate use of growth charts. So I appreciate that I'm speaking to an audience of doctors today from all across the Asian countries, and I'm very, very privileged to be able to do so. And in doing so, I also realized that our colleagues in various countries in Asia use different growth charts, quite rightly, and the growth charts should be based upon your obstetric population from which you are looking after your patients. So it's not what I believe, but there's enough evidence to suggest that locally derived growth charts are important, and they should be derived from your obstetric population, from the ultrasonic data, cross-sectional data of estimated weights or biometry that you've obtained from your population. I'm not particularly keen or believe that you should be using intergrowth charts which are published all on the WHO growth charts, and I'll show you some data to suggest why not. The one thing we are sure about is that you should never use birth weight derived growth charts upon which to chart your fetal growth, and that is because birth weight derived growth charts are all skewed downwards by the fact that premature babies that are born prematurely tend to be growth restricted. So that is something that you need to avoid. Of course, the question then is which growth chart should you use? Well, this and the next slide from a very elegant study done by the Chinese University of Hong Kong from Chang and colleagues. This is Derek Sahota's group, where they showed very elegantly that there are huge variations in the centiles depending on which graphs are used. And they've shown here a very nice set of 3 graphs looking at the 10th centile from their estimated fetal weight derived from the local population, and that's represented here by that straight dotted line. And you compare that with the 10th centile derived by intergrowth charts and also by the WHO charts. And these are the ones by WHO. These two are from the intergrowth charts. And you can see that there's quite a wide variation in the 10th centiles. And therefore, I'm not. It shows even more at the 50th centile here as well. So It is, I think, preferable that you use the estimated charts that you have from your own country. And just to give you some idea of how big the variations can be, from this publication from the same group, they've shown that you can have a percentage difference, depending on which chart you use, of up to 9.3%, especially if you look at the less than 10th centile. So you can have a variation of 8.5% between different growth charts. And therefore, it would suggest that you should use your own growth charts from your own local population. I would now move on to the assessment of serobiometry. If you have time, if you have a fetus that does not need to be delivered, and you monitor the fetal growth over time, you can also, of course, quantify the fetal growth. I mentioned a little bit about the dropping in centiles and of more than 2 quartiles. That would be fetal growth restriction. We shouldn't be measuring our fetuses more than 2 weeks apart, because the error, the inter-observer variability for estimated weight, is actually equivalent to the growth of a fetus per 2 weeks in the 3rd trimester of pregnancy. So any measurement before 2 weeks would be kind of meaningless and subject to errors that are as large as the change in estimated weight that you wish to demonstrate or quantify. This is data that we published many years ago. So plot your graphs by all means, but make sure they're at least 2 weeks apart. And you can plot them either with standard deviation scores or centiles, as shown here. Now we'll come to the meaty part of the talk, which I hope will be of interest to our clinicians. The importance of distinguishing between early and late growth restriction, very important, because the management is different. How you deliver your fetuses, when you deliver your fetuses, very, very different. And the point really is as follows. We have got criteria for distinguishing between early fetal growth restriction and late fetal growth restriction here. And these are actually criteria that was first published in the Delphi Consensus in the White Journal in 2016, and it has been used as the gold standard for distinguishing between early and late growth restriction in the latest ISWAP guidelines that were published in 2020. So just a little bit of detail here. We're talking about early growth restriction before 32 weeks, and we're talking about late fetal growth restriction after 32 weeks. The criteria for defining early IUGR, it's got to be one measurement of AC or estimated weight less than 3rd centile, or if you have abnormal umbilical artery Doppler studies, abnormal meaning absent or reverse, that's a definition of fetal growth restriction, or you can have a combination of these 3 different criteria as shown here. For late fetal growth restriction, you can make the diagnosis based on one measurement of estimated fetal weight or AC less than the 3rd centile, or you need at least 2 of the 3 here to make that diagnosis. For those of you who are watching online, I'm sure that these will be available on YouTube later, so you can always flick through these criteria. It's actually very helpful to have this reference in your ultrasound departments and also in your own clinics as well. So, as I mentioned, the ISWAP guidelines repeat these guidelines word for word, and this is now adopted as the ISWAP practice guideline for the diagnosis of either early or late fetal growth restriction. Now, the problem with early fetal growth restriction is that the controversies relate to management, as in having made the diagnosis, when do we deliver the fetus? Because as we know, the main concern is timing of delivery, and that is the main dilemma in the management of early fetal growth restriction. Of course, this is data that suggests that previously we can term late growth restriction as stage 1, and stage 2 to 4 was early fetal growth restriction. The timing of delivery is the main concern, and I'll spend more time on that later. Interestingly, the ISWAP guidelines don't really mention anything about stage 1, 2, 3, or 4, but early versus late. And I think that is correct. We just want to keep it simple for our clinicians. You've got to decide if it's early or it's late FGR. There are such differences in characteristics. Early FGR contributes about 30% to all the FGRs that we diagnose. A lot more of the FGRs are actually late FGR, 70%. Okay? As I mentioned, the challenge with early FGR is management. When do we scan our fetuses? When do we deliver? Less than 32 weeks, early FGR. The fetus may be very small, and we will have a spectrum of abnormalities involving either the umbilical artery Doppler, middle cerebral artery Doppler, and the ductus venosus. It's usually due to poor placentation, spiral artery abnormalities, and usually associated with a high perinatal mortality. By comparison, in late fetal growth restriction, the main challenge is detection, and I'll talk a little bit more about that later. The fetuses have to be more than 32 weeks. They're not necessarily small. The Dopplers involve really looking at the cerebral artery and the redistribution of blood to the middle cerebral artery. Not very clear placental abnormalities that are highlighted in late FGR, lower perinatal mortality. So early FGR, let's talk a little bit about this. It is something that has to be monitored according to the practice in your department. So you should have locally derived practice guidelines. You should also have a very good co-management with the neonatologists in your NICU, in your hospital, because a lot of this has to be managed together with their input as to the best achievable perinatal care involving neonatal care as well. And therefore, multidisciplinary approach is absolutely crucial, and you should get as much advice as you can from neonatologists and from your MFM specialists in your hospital. Monitoring is multimodal. You monitor everything. You monitor the CTG, you monitor all the Dopplers, fetal and placental, and you make decisions based on a combination of these results. And we then make decisions as to timing of delivery. There are certain absolute indications for delivery, and I think it's important to put it out there straight away. And that is to say, you put the Doppler on in your patient, and these are some of the criteria that we would say are absolute criteria. We put the scan on the machine, scan probe on your patient, and you find that there is absent end-diastolic flow, and the fetus is already 34 weeks or more. That is pretty much an indication for delivery, and there really is very little controversy about that. More than 32 weeks, if there is reverse flow, again, delivery. Now, depending on your practice in your hospital and in conjunction with your neonatologist, you can also you can actually move these goalposts slightly earlier if you have concurrence from your department and also from your MFM specialists and as well as your neonatologist. And in my hands, I would be very, very clear that I would move my goalposts earlier to 30 weeks and 32 weeks. Therefore, if it's 30 weeks or more and there's reverse flow, I would deliver. If it's 32 weeks or more and there's absent flow in the umbilical artery Doppler, I would deliver. And this is because of many prior discussions with the NICU staff and neonatologists who would be much happier handling a baby, even if a bit premature, but it delivered in a better condition. But this is a conversation you need to have with your neonatologists in your individual departments to come up with a rational decision before undertaking these deliveries. I'll just go to a little bit of umbilical artery Doppler. There's so much information out there. I really don't want to spend too much time on it. I think just to press home the point that if you're going to do umbilical artery Dopplers, please do it properly. Don't do it when the fetus is breathing. Like in this particular scenario, you can see the umbilical vein fluctuates, and this is classic fetal breathing. So try not to do any umbilical artery Doppler studies when the fetus is breathing. Wait for the fetal movements to stop, wait for the breathing to stop, then do your measurement, such that at least when you do it, it's like this. Yeah? You can see the umbilical artery vein is a very good proxy for the absence of fetal breathing, and then you can do your measurements accurately and also be able to make decisions based on these accurate measurements. Of course, what we're looking out for are either absent or reverse. So you can see that life is never so simple. Sometimes you get a hodgepodge of waveforms, and you get some waveforms that are absent here, And you get some where you can actually see reverse as well. So the question is it absent or is it reverse? Well, it does make a decision. It does make a difference if you're between 30 to 32 weeks. But I would put it to you that if it's more than 32 weeks, whether it's absent or reverse, the decision to deliver needs to be at the top of your mind. Now we come to the second important Doppler waveform in early FGR, and that is the ductus venosus. And it's important, I think, to put this slide here because I think that you get the best data if you use your ultrasound correctly, so you follow the guidelines. These are excellent guidelines from the New Zealand Maternal Fetal Medicine Society and also endorsed by the ASIM. And these are very, very helpful criteria that you need to adopt in order to do a good Doppler waveform of the ductus venosus. I'll run through this, but basically you need to do it when the fetus is not breathing, when the fetus is not moving. You need to achieve an angle of 60 degrees or less. You need to enlarge the image and reduce your gate. And the gate size of 1 millimeter or less is actually the same width of the gate that you would use in the first trimester when you look at ductus venosus. So I find it very helpful to get this special criteria set into my machine by the obstetric ultrasound specialists, so that I have a particular setting for ductus venosus. You set the wall filter low and the sweep speed high, and you optimize the spectral Doppler. Yep. So this is actually quite helpful. We do have many images sent to us where the pitfalls are quite obvious. Sometimes the gain is too high or the color flow is too low, and you have difficulty identifying the ductus amongst the other vessels that are nearby. Sometimes the gate is too large and it's not helpful when it's like that, or you put the sample at the wrong place, not at the inlet of the ductus venosus, like shown in this particular picture here. Or you sample the wrong adjacent vein, such as the hepatic vein, for example, by mistake. Or you do your sampling during fetal breathing, and that really gives you confusing waveforms to look at. So I think it's important to get your settings right. I'll just show you how not to do a ductus venosus, and here I think we have a very good example of when you, this is inappropriate ductus venosus waveform sampling, and simply looking at it you can tell that the waveforms vary, and that is because the fetus was actually demonstrating fetal breathing at that very moment in time. So you get variations, and this is uninterpretable. Same here in this particular waveform. Sometimes you think you've got two ductus venosus waveforms here. You might put your cursor, you might put your sample field between here and try and get a good DV pulsatility index. I still think that is prone to error, and you should have an entire set of waveforms that are performed during absence of fetal breathing. Next particular one shows you how it should be done. Here you can see beautiful, consistent, symmetric waves, yeah, and you can see that there's luxuriant flow during atrial systole. So there is no doubt that in this particular fetus there is no fetal hypoxia, and the PI of this particular fetus, ductus venosus, will be normal. Important to put your gate 1 mm and also at the inlet of the ductus venosus as it comes off the umbilical vein, as shown here. So what we're trying to do is to look out for absent or reverse flow during atrial systole, and this is an example of a ductus venosus with a reverse flow during atrial systole. And this is a very serious diagnosis to make, actually, because this actually means that delivery has to be contemplated at an even earlier gestation. Remember my two earlier gestations, 30 weeks and 32 weeks, depending on whether it's reverse umbilical or absent flow in the umbilical artery Doppler. Well, if you've got absent or reverse flow, if the A wave is at or below the baseline, that's what it means by absent or reverse flow, you may actually have to consider delivery as early as 26 weeks or beyond. Okay, and this is a serious diagnosis to make, and it it trumps really all other Doppler modalities in decision making between 26 and 30 weeks. So hence the importance of getting the ductus venosus done properly, either in your clinic or in the ultrasound department in your hospital, and making sure that the results are trustworthy. The problem is, what if you do not meet the criteria for delivery? How frequently do you monitor such growth-restricted fetuses? And the next few slides really will show that. I mean, I'm trying to show some data from some of the guidelines that are out there, and the summary is essentially that you should monitor the fetuses every 2 days until you meet the delivery criteria. So it's quite intense monitoring, and hence a lot of these pregnancies are either referred to high-risk centers, tertiary hospitals, or to MFM departments where such monitoring can be conducted every 2 days. Where do I get this 2 days from? Well, there are many guidelines. This is a fairly old guideline from the Royal College now, and I'm sure it will be updated soon, but this is from 2013. But even from that guideline, if you look here, we're looking at high-risk fetuses where there's absent or reverse endosteric flow. In this particular guideline, they actually suggest that we do daily umbilical artery Doppler and daily ductus venosus Doppler and daily CTG. In other guidelines, like this ASM guideline from the New Zealand Maternal Fetal Medicine Society, they do expect you to refer the fetus for same-day review by the maternal fetal medicine specialist for further assessment. In this study that was published quite a while back in 2009 by Turan and colleagues, we do get some idea of how many days we have prior to fetal demise, and we know that if you looked at all the Doppler waveforms of different fetal placental vessels, the outcome is particularly bad if you've got reverse atrial systole, flow during atrial systole in the ductus venosus, because you don't have much time. If you have reverse flow, usually demise occurs very, very soon, within a day or so. So that's why the interval for monitoring probably is every 1 to 2 days. The study by the Truffle study, which is pretty much adopted by the ISWAT guidelines, shows that if you do not meet the delivery criteria, repeat surveillance every 2 days. So the arrow goes back here, and you monitor the fetus using the umbilical artery and ductus venosus and the CTG every 2 days. Until you meet the criteria for delivery, then you deliver. How do we deliver the early growth-restricted fetus? The short answer is we are probably looking at an elective cesarean because of the high morbidity and mortality associated with labor in such fetuses. Particularly so if the CTG is already abnormal, if you've got abnormal ductus venosus Dopplers, as we mentioned just now, if you've got absent or reverse flow in the umbilical artery waveform, or you have very low biophysical scores, or if you have a maternal indication such as severe preeclampsia or imminent eclampsia, then the recommendation is elective cesarean section. Now, of course, prior to elective cesarean section, we need to remember two things. One, corticosteroid prophylaxis, and two, magnesium sulfate neuroprotection. One slide only on corticosteroid prophylaxis. I think it's a no-brainer. You can look at all the guidelines that are out there, and they all recommend corticosteroids before 34 weeks gestation to accelerate fetal pulmonary maturation. In fact, the Royal College guidelines recommend prophylaxis up to, well, pretty much up to 36 weeks gestation. So in my hands, I would have absolutely no qualms about giving maternal corticosteroids to any gestation up to 36 weeks prior to delivery in growth-restricted fetuses. So that is my cutoff. Magnesium sulfate prophylaxis, very important. There is good evidence to suggest that we should be using magnesium sulfate for fetal neuroprotection in preterm deliveries. Which gestation you give it to remains a little bit unclear. These are 4 of the studies that tried to address this, They use different cutoffs. In this study from France, less than 33 weeks. ACOP bulletin less than 32 weeks. The study from Adelaide, 30 weeks. And Stockley and colleagues, 29 weeks or less. Just to shed some light on this, the excellent meta-analysis published by Wolf and colleagues in the British Journal of ONG last year looked at the meta-analysis from the trials that were included in this particular meta-analysis, and they very, very extensive study, or meta-analysis rather, looking at data primarily from 6 big studies. And the general impression is that you should be offering neuroprotection, magnesium sulfate infusions 32 weeks or less as a general rule of thumb. And I would be very, very worried if there was no neuroprotection offered in any fetus less than 32 weeks gestation. These are large studies conducted in different countries, and you can see that it's also conducted in women of different ethnic origins. And you can see from the next slide that the bolus dose and the maintenance dose is very similar to what you would use for your patients who are preeclamptic, whom you worry about, who are destined, or you worry might actually fit upon you in your labor wards. So it's the same bolus dose, 4 grams, and then you maintenance dose either 1 or 2 grams per hour. And all of us obstetricians will be very familiar with this dosing regime. And it does actually make a difference to the incidence of cerebral palsy after delivery. And this is a meta-analysis that shows that if you use magnesium sulfate, you can actually reduce the risk of cerebral palsy by almost 32%. Any cerebral palsy, reduction in risk, 32%. If you look at moderate to severe cerebral palsy, the reduction in risk is about 37%, and that is a statistically significant reduction in risk. So important to remember 2 things. Give your mothers the steroid injection and sort out the magnesium sulfate neuroprophylaxis. You almost always have time for one, you have time for the other. Just to give you some idea, sometimes I've given this lecture before, and then I get asked by a lot of the clinicians, you talked about fetal growth restriction before 32 weeks, but you also talked about late fetal growth restriction, usually 37 weeks or more. What about this sort of no man's land between 32 and 36 weeks, you know? What do we do? How do we monitor the fetuses? How do we deliver these fetuses? When do we deliver these fetuses? By the strict criteria, anything after 32 weeks is late fetal growth restriction, but there is very good guidance on what you do in this gestation between 32 and 36. This is a fetus that I monitored, and you can see that there is definitely a fall off in the growth velocity, and whereas previously it was just below the 10th centile, is now progressively more and more below the 10th centile, and this was IUGR, or fetal growth restriction. Of course, I've gone past the 32-week cutoff, so this is now late fetal growth restriction. I kept monitoring the middle cerebral artery Dopplers. You can see there's a progressive reduction in the PI of the middle cerebral artery, which demonstrates brain sparing. And I kept monitoring the umbilical artery Dopplers until I got to a stage where the umbilical artery Dopplers demonstrated absent flow in the end diastole, which means that the PI here about 2.2, that to me was my indication for delivery, and therefore I delivered this fetus just before 34 weeks, at about 33 weeks plus gestation, because met my criteria, or the guidelines anyway, for delivery. So there is good data on late FGR as well. The main problem with late FGR is detection. The problem is that unlike early FGR, where most preterm stillbirths are related to smallness for gestational age, the surprise, or maybe not a surprise, is that most of the stillbirths at term occur in fetuses that are appropriately grown. That means they're actually not small. And if all the stillbirths at term, 60 to 70% are actually AGA, appropriate size for gestational age. And this is very, very good data from Poon and colleagues. And you can see from her data here that, whereas you can see here, these are all plots of babies that were stillborn, plotted against the growth charts. And you can see that before 32 weeks, a lot of them were small. Yeah? You can see that distributed down here below the mean for sure in most of them. Whereas if you look at the dot plots, the plots in term stillbirths, you can see that they're all over the place, and there's certainly no preponderance of smallness for gestation age amongst them. In fact, you can have a lot of stillbirths that are appropriately sized. And therefore, we have a dilemma in that we may be able to define late FGR, but we have to use different criteria than here. So what are the different criteria? Well, you can still do it if you've got one estimated weight or AC less than third centile. That still qualifies for late FGR. Or you need two of the three. You either have a abdominal circumference or estimated weight less than a 10th centile, plus one of these two. Yeah? Crossing of centiles, crossing 50 centiles, or you have a cerebral placental ratio less than the 5th centile, or the umbilical artery Doppler more than the 95th centile. You can see that this is another histogram of the distribution of umbilical artery Dopplers. Basically, this and the next graph histograms are actually to demonstrate that umbilical artery Doppler may be helpful in the preterm FGR up to 32 weeks, but very, very poor discriminatory value in late FGR. Because you can see most of the late FGRs have a normal umbilical artery Doppler. Okay? Same here. But when we look at the same gestations, you can see that if we use either an abnormal cerebral placental ratio or a small fetus, then we pick up more and more of the late or term FGRs, whereby some Doppler abnormalities contribute to the majority of these fetuses. So we need to use different Dopplers when we look at late FGR. Okay, now the issue with late FGR is, okay, first of all, we've got to make the correct diagnosis. Secondly, we need to know when to deliver. And a little bit more inconsistency, I'm afraid, on the timing of delivery in late FGR. Okay, the only randomized trial which is of help to us of a fetal growth restriction at term is the study published in the British Medical Journal in 2010. And this is the DIGITAT study, and there they induced labours versus expectant management in fetuses with suspected FGR beyond 36 weeks. The take-home message from this study was that the induction of labour did not actually affect the rates of instrumental delivery or caesarean. This gives us a lot of information on confronting the fallacy that if you were to induce your term fetuses, you're going to end up with a higher rate of caesarean sections, and that is actually not borne out in this large study, the DIGITAT study. So very useful information for us clinicians to put to our patients who are not keen on induction for whatever reason. If you have a fetus that is less than a third centile weight, you have a 1% risk of stillbirth, and therefore there is data to suggest that if you are birth weight third centile or less, you should not go past 38 weeks of pregnancy. And this is a good take-home message for all of us clinicians to remember. We do not want to basically monitor our patients till fetal death. And if your fetus is small, you're convinced it's less than a third centile weight, estimated weight or birth weight, you deliver the baby by 38 weeks gestation. And it always worries me when I have pregnancies referred to me past 38 weeks. The clinician knows the fetus is very small. Really, that fetus should have been delivered, not sent for further monitoring to an ultrasound department. So what criteria do we use to deliver a fetus in late FGR? Well, if you've got decelerations on your CTG, you deliver. If you've got a very inactive fetus that doesn't breathe, doesn't move, doesn't demonstrate any good fetal tone on your biophysical profile, you deliver. If the mother is severely preeclamptic or has HELP syndrome or an obstetric emergency, you deliver. If you've got abnormal changes on the CTG, you deliver. If you have an absent or reverse flow in the umbilical artery, you deliver. At any gestation, okay? So if you've got any of these criteria, you don't need any other indications to help you to support your decision for delivery. The problem is what happens if you don't have any of these criteria, and I suspect for those of us who've done this ultrasound monitoring for many years and decades, the majority will fall into this group, okay? There's no reason to deliver based on any of the criteria that I've mentioned above. Then you've entered 36 weeks, 37 weeks, 38 weeks. When do you deliver what you believe to be a late growth-restricted fetus? Well, there are two helpful indicators here. First, if you have an umbilical artery PI that is more than the 95th centile and you're already 36 or more, you can consider delivery. If you have an estimated fetal weight less than 3rd centile, if you're between 36 to 38 weeks, you can consider delivery. If you have evidence of cerebral blood flow redistribution and you're between 38 to 39 weeks, you may consider delivery. I think these are helpful guidelines to help us to manage fetuses in late FGR. Majority will fall into this group. Of course, I will talk a little bit more about some of the other contentious issues with late growth restriction monitoring, but that's coming up. So we would want to do fetal Doppler studies, but the choice of Doppler parameters are very different. We are essentially looking at umbilical artery Doppler, middle cerebral artery Doppler, and therefore you calculate the cerebral-placental ratio. This will be recommended in the monitoring of late growth restriction. Let's talk a little bit about the cerebral artery NO, and therefore by implication the cerebral-placental ratio. This is not new to most of us. We know since 2007 these charts have been produced and they have been used in the clinical practice. And this is the chart from Ebbing and colleagues published in 2007, whereby you measure the middle cerebral artery PI and then you divide it by the umbilical artery PI, and then you get a ratio or number, and then you plot it on the graphs. And the lower the CPR, the more cerebral sparing has occurred, and the greater the severity of the fetal growth restriction. So this is the premise on which the CPR is derived. Now, of course, to calculate the CPR correctly, you should do your middle cerebral artery Dopplers appropriately. And I would say I'm just going to demonstrate one pitfall, I would say, in the measurement of the middle cerebral artery Doppler, which you should try and avoid. And that is the amount of pressure that you exert with your transducer on the maternal abdomen. Basically, when you do the middle cerebral artery Doppler, make sure that you don't press too hard on the fetal head, because it can cause an artificially increased it can cause an artificial change in your middle cerebral artery Doppler. And I'll demonstrate it in this and the next slide. So this is a Doppler of the middle cerebral artery, whereby you can see the red flow going upwards, and it's the middle cerebral artery Doppler vessel, as you know, is situated just above the greater wing of the sphenoid bone in the brain, and the middle cerebral artery is assessed here. Very light touch. That's the key. Don't press too hard. Now, if you see this, you can see that there's a normal cerebral artery waveform here with quite low flow during diastole, and that's normal. Same fetus, 5 seconds later, I'm going to press a bit harder on the fetal head, and look what happens. Same fetus, 5 seconds later, nothing has changed except the amount of pressure I exert on the fetal head, and I can artificially increase, or rather I can artificially reduce the PI, okay? And this will give me an erroneous impression that there is cerebral artery sparing. And of course that is not correct. So however you scan your middle cerebral artery Doppler, just make sure you lift your transducer a little bit off the abdomen and make sure that you're not pressing too hard on the fetal abdomen. And then you will get the correct waveform for the correct assessment. Let's look at this. Of course, we have charts for middle cerebral artery PI. On its own, I would say it's helpful, but not as helpful as if you were to plot your results on the cerebral placental ratio. And this is basically the MCA PI over the umbilical artery PI. And most clinicians would use the fifth centile cutoff to determine whether there is cerebral sparing or not. Now, I would show you some of a quick reference table. This is a quick way of remembering the cutoffs. Now, most of us have trouble remembering the cutoffs, and of course that's why we use graphs, but I have a simple trick and a way of remembering my cutoffs, my fifth centiles basically. And I look at the reference tables for these centiles, and I will, yep, I don't seem to have this particular graph here. Yeah, that's right. The 95th, yeah, I can show it to you here. This is, I would like you to fix your eyes on the 38th week, yeah, because this is usually when decisions have to be made. Yeah? You're finding a reason to deliver the fetus, no criteria has come up yet, and you do the middle cerebral artery, umbilical artery at 38 weeks. I've got a middle cerebral artery cutoff of 1. I've got a umbilical artery cutoff of 1, MCA-PI cutoff of 1.2, and the cerebral placental ratio CPR 1.4. That's how I remember it when I scan a fetus and I'm not looking at the graphs yet. So if I've got a umbilical artery PI more than 1.0, that is above the 95th centile, that is actually one of the criteria for delivery. Middle cerebral artery PI on its own, not so helpful as I said, but 1.2 or less, it's cerebral sparing, especially if you do the ratio and you find that it's less than 1.4, that's cerebral sparing, and that again would be a criteria for delivery between 38 to 39 weeks. The use of the ratios has been shown for many years. We did this work back in the 90s, and we showed that when you lose ratios of the middle cerebral artery over other vessels in the body, you get a much better detection rate given a certain specificity as shown in these ROC curves compared with single vessel Doppler studies. As shown here, the highest odds ratios are usually those associated with ratios between the middle cerebral artery and other vessels in the body. So just to give you some idea why the CPR, the cerebral placental ratio, is better than the middle cerebral artery PI. This is a very good meta-analysis published in 2018 by Wolfgraf and colleagues, whereby it was demonstrated that whether you predict perinatal deaths or adverse perinatal outcome, you can see that the ROC curve nearest this left side of the graph is actually usually shown by the CPR as opposed to the other curve, which is demonstrated by the middle cerebral artery PI. So the take-home message, use the CPR if you're going to use it at all, and not the middle cerebral artery PI when making decisions. There are still, nevertheless, many controversies, and this I do not want to suggest that that we are very divided as to the opinions, but these are some of the practical issues that will creep up. Look, which graph do we use? It's not just the Ebbing graph that is available. There's also the graph by Bashard. What cutoff should we use? Should we use the 2.5th centile, 5th centile, 10th centile? And when should we deliver the fetus once the CPR threshold is reached? That I hope the ISWAC guidelines has given us some information, some guidance on. And just when we get used to the idea of the CPR, there are recent studies that suggest that we should flip the ratio around the other way and call it the umbilical cerebral ratio, or the UCR. Well, let's go through some of these controversies. Good to discuss these, think about these. I'll just put here the two graphs that are available to clinicians. Some of you using software will have the bus chart graphs. Here you can see the bus chart graph, and here on the right side you've got the graph by Ebbing. Of course, you can see that there are very subtle there are subtle differences between these two graphs, albeit granted that this is using the 2.5th centile and this is using the 5th centile, but you can see that even if you imagine the 5th centile for the bus chart, the bus chart CPR is actually set a little bit lower than the Ebbing CPR. So again, which graph do you choose? Personally, I choose the bus chart graph because I find it very easy to use, and it fits more with my clinical practice. But you have to have that decision made in your individual departments that you run. The use of the CPR varies. There are studies that have used the cutoff of 5th centile, as I alluded to earlier, as in this study by Caradu and colleagues. There are other studies, like the study published by Bly and colleagues, a very good paper actually, whereby they looked at the 1st, 5th and 10th centile, and these were the CPRs that were all measured within 2 weeks before birth. And they demonstrated that you had the highest sensitivities and detection rates if you used the CPR of less than 10th centile prior to birth. So you can see that the obstetric literature is a little bit divided as to what centile should be used for defining cerebral sparing that leads to delivery. This is another ROC curve in the same paper by Bly that shows that the highest ROC, the graph, the curve nearest the y-axis here is using the 10th centile as the cutoff. This is a very interesting paper, a very good paper, which has been interpreted wrongly by some clinicians to mean that if you have an CPR ratio that is abnormal, you must deliver within 2 weeks of birth. You must deliver within 2 weeks. It doesn't say that, okay? All this paper tells you is that they collected data on the CPR within 2 weeks of birth. It doesn't tell you to deliver the fetus within 2 weeks if you have an abnormal CPR. As I said, you have to go back to the ISWAC guidelines to help you make that decision. And the ISWAC guidelines are now very clear. I would just maybe, for the benefit of time, just spend a little bit on the umbilical cerebral ratio, which may come up in subsequent papers, because this is just a flip of the CPR. So you flip it around such that you have the umbilical artery PI as the numerator and the middle cerebral artery PI as the denominator. Some studies coming out to show that that is very helpful in determining the severity of the fetal growth restriction, as shown here, where the last score prior to delivery did predict adverse perinatal outcome. We will see how the literature pans out in the coming years. I think this is a helpful summary. This is from the ISWAC guidelines, and I think we have clear cutoffs to help us make decisions as to when we should be delivering the fetus. As I said, for late fetal growth restriction, we have very helpful guidelines here. 36 weeks or more if the umbilical artery PI is more than the 95th centile, or your AC or EFW is below the 3rd centile, you may consider delivery, and you should deliver them by 38 weeks. If you have evidence of cerebral redistribution with a CPR of less than the 5th centile, you may deliver any time from 38 to 39 weeks, i.e. you should deliver the fetus by 39 weeks. So these, I hope, will be helpful criteria that you can remember, and which will help you very much in your management of late FGR. The future, well, we've got very interesting studies coming up, and in the interest of time, I think I would just mention them, and they will certainly provoke further discussions in years to come. We've got the Truffle 2 coming up, the PROMISE study, ratio 37, and I thought I'll just finish off by reviewing some of the recent information coming from the use of superb microvascular imaging technology, or the SMI, which is proprietary to the Canon ultrasound machine. Very interesting way, I think, of quantifying or semi-quantifying what we have known for a while. And that is what, we've always looked at placentas in these growth-restricted fetuses. They're big, they are jelly-like, they move when we shake the placenta with our transducers, they're wobbly, and we know that the placenta is unhealthy, but how do we quantify or semi-quantify it to help us refine our management of such pregnancies? And this is some data that came from the group from the University of Kagawa in Japan. Professor Hata and his colleagues published about 3 years ago some very interesting data on the use of the SMI technology in the placentas of growth-restricted fetuses. And I think what we're trying to show you here are that you can actually, using this special imaging technique, you can actually look at primary stem villi, secondary stem villi, and tertiary stem villi, and they're like the branches of a Christmas tree. They actually have lots of branches coming off each of these 3 different types of villi. And if you had the ability to do the 3D imaging and render it this way, you can see that there are lots of offshoots from the primary stem, secondary stem, and the tertiary stem villi. And this will be a healthy pregnancy, abundant flow through these villi at the 3 different levels. If you compare that with the next set of slides, where we can see this big wobbly placenta with lots of venous lakes, and when you put the SMI imaging on, you can see this, it's like a drain pipe, There are very few branches coming off the primary stem villi, very few branches coming off the secondary stem villi, and none coming off the tertiary stem villi. So it's like a dried up, desiccated tree with very few branches. And this is something that may be of use in the future. I'm certainly very excited about it, because I've been using it on a lot of the fetuses that I've been referred to with placental growth restriction, and here are some of the ones that I've looked at recently. This is a patient with a normal placenta, with a normally grown fetus. All the Dopplers are perfect, plenty of fluid around the baby, and you can see as I move my probe, and you can look at these villi, you can see the primary, secondary, and tertiary. See all these beautiful branches from the tertiary stem villi as we approach the decidual vessels. These are the decidual vessels shown beautifully here. You can actually look at placenta accreta as well, but that's another topic for another lecture. But you can see the abundant branches from the tertiary stem villi. And this is a very healthy placenta. Another slide to show you the same. Look at these abundant tertiary stem villi here. And now we compare that with the next series of slides in different fetuses with growth restriction. Now here is a fetus that I've got a still image of, where I've traced the tertiary villi, and I cannot find many or any branches. It's rather sparse branching here. Same here. I'm tracing the vessels, and you can see it doesn't light up like a Christmas tree. There are very, very few branches of the primary, secondary, and tertiary stem villi. And if I use the, of course, it will light up. You see this drain pipe appearance here, whereby the vessel goes straight up with very, very few branches. And this is the primary stem villi that I'm looking at here. Highlighted even more in this particular SMI image here, where you can see these straight vessels going up, very few branches here, like a drain pipe appearance. And I'll show that to you with an arrow on this next slide here. If you concentrate here, you can see what I mean by these vessels with very few branches. So I think in years to come, we would have a lot more data on this. in semi-quantifying the quality of the placental villi, stem arteries, and that may help us in management of the growth-restricted fetuses in the years to come. So I thought I'll leave that with you as a food for thought as we anticipate more information on this in the future.